Okay. All right. Should we then proceed to the next question?
Yep, we could start.
Okay. Mm, yeah. Yeah. So this is the first question.
If you have Slido open, it should be showing for you on your screen.
So we have the candidate who is going to be on the hot seat for this question.
I think I forgot. Would anyone like to take this case, or I'll just pick one of you? I'll just give them a minute to go through the case. Is there anyone who'd like to take this case? Okay, Thierry, I think I'm gonna call on you
Hmm.
because you're the first one on my screen. Would you be able to take this question?
It's going to be more of interactive, so I guess I would encourage everyone to participate. It's going to be helpful for the candidate who's going to take the question because it's going to deepen your understanding of the question better.
Okay, I can take it, Lucas here. I can take the question.
Thanks, Lukasz.
So shall we make a start or?
Yeah,
Go ahead.
if you want to, yeah, you want to give me the answer and then you want to discuss it a bit of whatever you know about this.
Okay. So I think it is the DTGA, so transmitted weight vessels, as the virus presents earlier.
Mhm.
Reasons for this is, first of all, we've got a 2-month-old with cyanosis, so it's an early presentation of whatever the condition is. There is the egg on a string appearance, which are yeah, so egg on a side appearance. So I think that basically is characteristic for TGA, and
Mhm.
also the baby is dependent on the baby is dependent on patent ductus arteriosus for the circulation.
Right,
So that means that's yeah, with TGA they are duct dependent basically. So I think that's why it is.
right. And why do you think it's not the LTGA?
Doesn't LTGA present later?
Okay. All right. So your approach is right. And can we show the polling results now, Becky?
You just move to the next slide and it'll show it.
Right. I can do that myself. Okay.
Mhm.
Okay. Right. So DTGA is the right answer. And we have a LTGA 40%, and some have written tetralogy. Nobody's picked up TAPVR. Okay, so let's go to the explanation of this. So, what I would sort of want all of you all to participate is while I'm discussing this, is basically the congenital heart diseases are of two types. The cyanotic and the non-cyanotic ones. So, and they have to give this information to you in the exam, otherwise they cannot expect an answer. So the question stem does mention that the baby is cyanotic. So when we say cyanosis, what does it mean? It means that there is deoxygenated blood going into the systemic circulation, because of which the baby is blue. So the typical common causes of a cyanotic heart diseases are the 5 or the 6 T's which are listed there. And you then have the non-cyanotic ones, which have a shunt going from the left side of the heart to the right side of the heart. Um, and this does not result in cyanosis. So we'll stick our discussion to the cyanotic in the present context. So you have the 5 T's here. So the first is the tetralogy of Fallot. So the tetralogy of Fallot, as we are all aware, has got 4 components. It has got a VSD, it has got right ventricular outflow tract obstruction, and the severity of the disease depends upon how bad the right ventricular outflow obstruction is. So if the right ventricular outflow tract obstruction, or the RVOT obstruction, is severe, then you're going to have basically the blood flowing from the right ventricle to the left ventricle, and that is where your deoxygenated blood is going to go into systemic circulation and the child is going to be cyanotic. Whereas if you have a milder variety of RVOT or narrowing, then you will have sort of a pink fallow, as they say, where there is no cyanosis happening. The other 2 components being overriding of the aorta, and because there's lots of blood coming into the right ventricle, you will have right ventricular hypertrophy. And that typically gives rise to the boot-shaped heart with upturned apex that's typically described. So this case does not have that typical appearance. It does not have, it does mention egg on string. It doesn't say a boot-shaped heart. So these are certain buzzwords you need to remember. They will be sometimes given to you in the question stem and you can pick the right answer. Then you have the TAPVR, which is the totally anomalous pulmonary venous return. Basically, as we know, in our normal circulation, you have the venous blood from the extremities and the upper extremities coming in from the right atrium, coming to the right atrium from the SVC and the IVC, which then goes into the right ventricle and the pulmonary artery, while you have the blood coming in from the pulmonary veins going into the left atrium and the left ventricle and into the aorta. Now, whenever there is an anomalous return of blood into the right-sided circulations, you will have a totally anomalous pulmonary venous return. Now, this can happen above the level of the heart, say at the level of the brachiocephalic or the subclavians or the SVC, where the blood from the pulmonary veins is going to go into the right side of the circulation, right? Or you can have it at the level of the heart, where you have a cardiac type of TAPVR, or you can have an infracardiac type where the blood isn't going to enter the hepatic veins or the IVC. So depending upon where the location is, it is type 1, type 2, and type 3. So the typical snowman's heart or the figure of 8 heart is when you have a supracardiac type of a TAPVR. Again, this question stem doesn't describe that, so this is not a TAPVR. I'll come to the transposition, but I'll just quickly finish with truncus and tricuspid atresia. So in truncus, you have a single arterial trunk, or a single trunk rather, which is supplying blood, or there's the aorta and the pulmonary artery are both coming off from that single truncus. So obviously there is going to be mixing of the oxygenated and deoxygenated blood, and the child is going to be cyanotic. Uh, Tricuspid atresia is where the tricuspid valve is atretic and the right ventricle is hypoplastic. You need to have a VSD or an ASD so that the blood will then flow from the right side to the left side of the heart, because there is no blood moving in out from the right ventricle, because right ventricle per se is hypoplastic. So that is the condition where the child gets cyanosis. Now, when you come to transposition, um, you have the DTGA and the LTGA. Now, the D is the dangerous type, and I'll explain why. And this requires a PDA for the child to be alive. Um, and it requires prostaglandin E1 to maintain the PDA open until the child undergoes surgery, which is what described in the question stem. The LTGA is lucky, that the patient is lucky to be alive. That's how I remember it. And I'll just explain it to you quickly. So this sort of flow chart or a simple line diagram explains you the difference between a DTGA and an LTGA. So what is happening in the DTGA is basically the oxygenated blood and the deoxygenated blood are running separately from each other. So for example, you have from the left ventricle the pulmonary artery coming off. So that is where the transposition of the great vessel comes in, right? So normally from the left ventricle you would have the aorta coming off, but here you have the pulmonary artery. It's going into the lungs, coming back to the left atrium via pulmonary veins, again going back into the left ventricle. So this is like an isolated oxygenated circuit that is running. Whereas from the right ventricle, you are having the aorta coming up, which is supplying blood to the systemic to the body, and then coming back to the right atrium and going back into the right ventricle. So this is the deoxygenated circuit running here, and these two are running separately unless there is a PDA. So only if there is a PDA, then can the mixture of blood happen and the child can survive. Now, I mentioned that the LTGA is lucky to be alive. So what happens in an LTGA is that basically, how I remember it is like a double switch, which is basically what is the atria switch ventricles and the ventricles switch the great vessels. So ultimately blood ends up being in the right place. So for example, the right atrium normally, goes into the right ventricle, but here the right atrium will go into the left ventricle. And from the left ventricle, instead of the aorta, you will have the pulmonary artery. So you see the switch has happened at two levels. From the right atrium, it is going to the left ventricle, and from the left ventricle, again, it is going back to the pulmonary artery. So the blood is ultimately going from the right atrium to the pulmonary artery only, and it is going to the lungs. Similarly, on the other side, if you see from the left atrium, you have left atrium draining into the right ventricle, and from the right ventricle the aorta is arising. Again, there is a switch at two levels which is happening, right? So ultimately the blood from the left atrium is going to go into the aorta and then supply the body. So this is where the double switch happens, and that is why this LTGA is a congenitally corrected type of TGA, and it does not require a PDA to function. The child can still be alive, but this is not compatible unless there is a TGA that is present, right? So now this again, this is another flow chart which can sort of help you to answer questions based on whether the child is cyanotic, non-cyanotic, and what side is the aortic arch, and what's the heart size and the pulmonary blood flow. Now, if I just have to explain you simply, like say example, you take the example of tetralogy of Fallot. Okay, we know that the right ventricular outflow tract obstruction is going to determine the severity. So if the RVOT obstruction is severe, then you will have reduced pulmonary blood flow, or you might have normal blood flow. Heart size is going to be normal, and the arch is going to be on the left. The child is going to be cyanotic. So you can work yourself backwards like this and come to the answer. So in the question stem, they might say that the child is cyanotic, the arch is on the left, heart size is normal, pulmonary vasculature is reduced. So what's the diagnosis? So this is how sort of this can help you to answer the questions. And you can do this for pretty much anything else if you know the underlying mechanism. Like say for a TAPVR, you know that there is going to be lots of blood which is going to go to the right side of the heart because all the pulmonary veins are coming into the right side of the circulation. So you're going to have increased pulmonary blood flow. Heart size is going to be normal, arch is going to be on the left, but the child is still cyanotic. So you see the pulmonary blood flow can sometimes help you to answer the questions whether it is an increased blood flow or decreased blood flow. Now, if you think of Epstein's and tricuspid atresia, usually they will also have some cardiomegaly associated with them, and some other associated anomalies can also be present. But they will ask you at least to test your basic understanding, whether you've sort of understood the underlying pathophysiology and how the blood is flowing in different systems. Uh, if there are any questions, we can take them now. And this is just to sort of show you the typical appearance. The Agon string is in transposition, Snowman's is in the supracardiac TAPVR, boot-shaped heart is in tetralogy of Fallot. Coarctation, again, a left to right shunt, but you have the figure of 3 appearance here, box-shaped heart in Epstein's anomaly, and the scimitar appearance in a PAPVR with hypoplasia. So these are certain buzzwords which you might be given in the exam that can help you to narrow down the option. Okay. Any questions, or we can move on to the next candidate?
Is there any question?
Okay. I think we can then take the next
question.
candidate if, yeah.
If you could move to the next slide, and then we'll give them a minute or two to just read through the question.
Yep, I'll do that now.
Okay, so if everyone could head to Slido again and then take a look at the question, and if ever anybody would like to take that case and be on the hot seat, that would be nice, or else I can maybe pick one of you. Sarah, would you like to take the case?
Yeah, that's fine. I'm actually not sure about this one.
No worries.
So
So this question is just basically testing you the different bone marrow edema patterns around the knee. Um,
yeah, so I know what it isn't.
mhm,
It doesn't look like patellar dislocation,
right.
because you'd get contusion on the patella as well as on the femoral condyle.
Hmm.
I've gone for a dashboard injury,
Okay.
just because I feel like the hyperextension injury, you'd also get bone marrow edema in the patella.
Right.
Clip injury, possibly.
Okay. No worries. So,
Um,
sh-
but
um, so
I don't know on this one, unfortunately.
no worries. So we'll sort of sort this out in the explanation. So let me quickly go to the polling. All right. So pivot shift and dashboard. Um, some set clip. Okay. Yes, I'm sorry. Oh, okay. Yeah. So the answer is pivot shift. Okay. Now let me go to the explanation. So this is what is a pivot shift injury. So it is basically a non-contact sport injury. That's point one. Second is it typically happens during skiing accidents where you see that there is internal rotation of the femur on the tibia, which is relatively fixed in position. This you can see in the schematic here. Um, because of the femur being rotated on the tibia, the anterior cruciate ligament is going to get torn. Right now, when the femur is going to rotate on the tibia, after the anterior cruciate ligament tears away, you will have the femoral condyle hitting on the tibial condyle at a very particular point. The posterior aspect of the or the posterolateral aspect of the lateral femoral condyle is going to hit against the posterolateral aspect of the tibial condyle, right? The lateral aspect of the tibial condyle posteriorly. So this is the typical bone marrow edema pattern you're going to get, and you will get the tear of the anterior cruciate ligament. So if you go back to the question stem, uh, it does say that there is bone marrow edema in posterolateral tibial plateau, to a lesser extent in the lateral femoral condyle, and ACL has amorphous appearance with fluid signal through it, which means it's describing you an ACL tear. And there is a tear in the posterior horn of the lateral meniscus, which is not very difficult now to understand, because when you have this femur pressing against the tibia, the medial meniscus is going to get crushed, right? And there might be a potential injury through the lateral collateral ligament as well. So this is, if you remember this picture and you remember the schematic, you will sort of you'll be able to make sense where the bone marrow edema is going to be, right? And why is the bone marrow edema there? First of all, because the ACL is torn. So when the ACL is torn, femur is going to hit the tibia at the posterior aspect. You're going to get the tear in the posterior horn of lateral meniscus and potentially a lateral collateral ligament injury. Now let's go through the other options. So this is the hyperextension injury. Again, this could be a contact sport injury or somebody who is sort of hyperextended the knee. So when hyperextension of the knee happens, what's going to happen is that the tibia is going to move more than what its physiological range of motion is with respect to the femur. So the anterior aspect of the femoral condyle and the anterior aspect of the tibial plateau will have bone marrow edema pattern, which is shown by this hatch here. And because of this, because of the excessive anterior translation, you are going to get a tear in the posterior cruciate ligament. Right, so hyperextension injury probably makes sense now. This is going to go way up. It's going to cause marrow edema in the anterior aspect of the femoral condyle, anterior aspect of the tibial condyle, and a posterior cruciate ligament tear. Now, Now, what's a clip injury? So clip injury is contact sport injury. Sometimes they might tell you it's an sort of a rugby player or an American football player, and he gets tackled, and then he has this typical marrow edema. So somebody's tackling somebody from the lateral aspect. So the trauma is going to be more on this side. So you're going to have major bone marrow edema on the lateral femoral condyle, to a lesser extent on the medial femoral condyle. Now, because of the trauma happening this way, you're going to have the medial collateral ligament tearing up, right? So that's the typical injury pattern in clip injury: marrow edema on the lateral, to a lesser extent on the medial femoral condyle, and a complete tear of the medial collateral ligament. Now, we come to the dashboard injury. Now, what does a dashboard injury? Quite explanatory. When you have a person's knee hitting against the dashboard, you're going to have bone marrow edema pattern on the anterior aspect of the tibia, and you're going to have a posterior cruciate ligament tear. Now, it's important to differentiate this from a hyperextension injury. If you go back and you see hyperextension injury as bone marrow edema at the femur, tibia, and a posterior cruciate ligament tear. Whereas here, because of the mechanism of injury, you do not have marrow edema on the femur, you only have it on the tibia, and you have a posterior cruciate ligament tear. So that's another way of asking you the question, depending upon the bone marrow edema pattern, right? Whether the marrow edema is present on the femur or not. And then you're then asked to guess what could be the type of injury. Is this a dashboard injury, or is this a hyperextension injury? So you would then want to make sure that whether marrow edema is present or absent. If it is absent here and these two findings are there, then it's dashboard. If you have marrow edema here, and then you have this tear, then it's a hyperextension injury. All right. Then I guess we are all familiar with this, the patellar dislocation. Ballet dancers or somebody who is in this particular position where the femur is again getting rotated against a outwardly rotated tibia, and there is further downward pressure. What's going to happen is that the tibia, the patella is going to dislocate laterally, and you are going to have marrow edema on the medial aspect of the patellar condyle, patellar pole, medial patellar pole, and the lateral aspect of the femoral condyle, and there is going to be a tear in the medial patellofemoral ligament, right? So medial patella, lateral femur, and the tear of the medial patellofemoral ligament. And these patellas can sometimes relocate back to their normal position at the time of imaging, but the marrow edema is quite characteristic. We may not always see the dislocated patella, but you have to pick up the marrow edema and the tear so as to then deduce that this could be a transient patellar dislocation which has relocated back. And then you go back to the history and try to decipher what's the mechanism of injury which has led to this. So any questions, or we can move on to the next?
And do you see with the pivot shift injuries, is it usually the medial meniscus that's injured rather than the lateral, or does it just sort of depend? Because I kind of thought you can sometimes get that unhappy triad with the pivot shift injury.
Yeah, you can get the unhappy triad with the pivot shift, but there are recent papers which say that what was initially described in the terrible triad of O'Donoghue was the medial meniscal tear, but now there are some papers which say that you have, in fact, the lateral meniscal tears being more common than the medial meniscal tears. And if you look at the mechanism of injury, it sort of maybe makes more sense also, because when you have the femur and the tibia getting pressed on the lateral aspect, I would expect a tear more here than on the medial side. Of course, the space is quite widened and you might have degenerative changes and maybe potential tears coming up. But what is typically described is the ACL being gone and the posterior of lateral meniscus being the one which is more affected. That's probably just purely based on the mechanism of injury, I suppose.
Great, thank you.
All right. Okay. Can we move on to the next candidate, please? And I'll just show the question.
Sure, I'll give this turn to Noha. If you are there, could you unmute once you've had a chance to read through the question?
So this question has got options which are longer, and I'm going to be scrolling down slowly. just so that you all can read through all the options. This is the third option.
Noha, are you here? Are you able to unmute and speak?
Yes,
Yeah, perfect. Would you like to take this case?
that's okay.
Yeah, perfect.
Okay. Please let me know in the chat, or you can just speak up if you want me to show you all any particular option again, because the options are longer. So I'll just scroll this
It's
once more.
confusing, sorry.
Yeah,
For me, it's confusing.
it's confusing by design. I'm sorry, because the exam can be like this, where you have a very short stem, and then they sort of want you to read through the explanations in detail and come up with the answer. Just feel free to discuss and just speak up. Don't worry if you're wrong, it's fine. Just tell me what you're thinking.
Okay, so I cannot do this, sorry.
Okay, should we then go to the poll?
Yeah, sure. Is there anyone else who would like to take this case?
Anybody can guess. You don't need to be on the so-called hot seat. You can just speak up and tell the answer as well, no problem.
I think I know which one is the answer.
Mhm.
I don't I don't know much factual knowledge here, but basically I think the answer to this question is that as in the incorrect statement is the
Mhm.
right common iliac vein compressed by left common iliac artery, because it's I
Mhm.
think the other way around. So it's the left common iliac vein compressed by the right common iliac artery.
That's right. That is the answer, actually.
But I don't know any of the other statements why they're true and about them.
Yeah, no worries. But you're right in the answer. So the correct answer is the right common iliac vein getting compressed by the left, causing May-Turner syndrome. So let's go back and discuss this. So, like you mentioned, the May-Turner syndrome, basically, if you have to remember, because this left and right can get confusing. So the way I would remember it is that these patients have repeated left-sided DVTs because of the left common iliac vein that gets compressed between the right common iliac artery and the lumbar vertebra, or between the two, right? So repeated left-sided DVTs, so the vein is going to be on the left, right? Because the DVT is on the left. So that's how I remember that. So these are typically vascular compression syndromes in the abdomen, which you may be aware of. And it's good to know them because MCQs can come up on that. So that's May-Turner syndrome. Now, what's the SMA syndrome? SMA syndrome is basically when you have the duodenum that is getting caught between the aorta and the superior mesenteric artery, right? That's specifically the third part of the duodenum that's getting caught between it. Now, if you've ever looked at your CT abdomen images, uh, especially on the sagittal arterial phase images, you will usually appreciate a very good amount of fat between the aorta and the SMA. That is where the duodenum runs through. But if for any reason the fat is lost, either because of weight loss or because of surgery or because of malnutrition, then the duodenum risks getting compressed between the aorta and the SMA. And typically, the patient is going to then present with postprandial pain. They'll be vomiting, uh, which is fairly easy to understand because the duodenum is getting compressed, so everything is going to get backed up proximally, and the patient is going to throw up. Usually, young females, as described in books, are commonly seen, but it can be seen in anybody who is sort of lost weight or has had malnutrition or so forth. Uh, Diagnosis can be done based on clinical suspicion and a CT angiogram of the abdomen, which is then going to show this narrowing. And there are certain measurements that we do, the distance between the aorta and the SMA, and the angle that it creates on a sagittal arterial phase image. And these certain angles you might be wanting to know, which is also mentioned here. Let me scroll that up if I can. Okay, yeah. So the angle of less than 22 degrees and the distance of less than 8 millimeters is what defines a SMA syndrome. Okay. Uh, Now, what's the nutcracker syndrome? It is basically where the left renal vein is now getting caught between the aorta and the SMA. If you can imagine the left renal vein as it comes up and getting caught between the aorta and the SMA as it is draining into the IVC. So it's going to go to the IVC, but before going there, it is getting caught between the aorta and the SMA. And this is going to give rise to the typical beak sign that is described. Now, if you can imagine, patients can sometimes present with the left-sided varicocele because the left renal vein is getting compressed. So that is going to cause back pressure in sort of the venous flow. And the patient's initial presentation could be testicular pain or left-sided scrotal pain. You do a left varicocele, and then it is diagnosed to have nutcracker syndrome. So that's nutcracker syndrome there. And then you finally have the median arcuate ligament syndrome, where basically we all have a median arcuate ligament, but only when it is thick or say more than 6 millimeters is what is described, causing compression of the celiac trunk. Now, the question stem does say that the 30 to 50% of asymptomatic individuals can show compression of celiac artery, which is a true statement, because this thickening by itself does not mean that the patient has got median arcuate ligament syndrome. What qualifies as the syndrome is when the patient has got clinical symptoms because of that. For example, you have postprandial pain, you have the median arcuate ligament which is thick, more than 6 millimeters. You have post-stenotic dilatation of the celiac artery, right? Whenever there is a hook-shaped narrowing of the celiac artery, there is a post-stenotic dilatation that is happening. And you have the Doppler parameters which are mentioned in the stem, um, which is of the Doppler velocity of being more than 200 centimeters per second in the celiac artery is sensitive and specific in diagnosing 70% cases of median arcuate ligament syndrome. So this is a true statement. This is a true statement, right? But the right getting compressed by the left is the wrong one, because we know now that it's the left iliac vein, left common iliac getting compressed by the right common iliac artery. All right. Okay, so we'll just move on to the next question. And if anybody wants to be on the hot seat. So this question is asking you the most appropriate imaging protocol for this particular case. I'm just going to slightly scroll up. Okay, so this is the last option here. And this is the first option, or first four options.
G, would you like to take this case?
Yeah, I can give it a go. So, should I wait until the poll's out, or should I start?
No, you can,
just yeah.
yeah, give me your thoughts, no problem.
Actually, I'm sorry, I've just realized that I've missed a part of the information. I basically chose the nephrogenic phase without realizing that it was a split bolus technique. But the reason I chose the nephrogenic phase was because with pyelonephritis, I thought it would be more of more dependent on the findings of the parenchyma of the kidneys themselves rather than what we can see on the excretory phases. So I've ruled out I think there are two options with 5-minute and 10-minute excretory phases, because I wasn't really sure if they would be very helpful with this. And it was the same with arterial phase as well. We're not really looking for kind of arterial cause here.
Right.
But I'm just wondering whether just a single bolus technique in portal venous phase would have been sufficient for pyelonephritis.
So you know what is the split bolus technique? Have you been using it in your practice?
Split bolus for I don't think so. I think we normally go for single bolus, but just in different timings, whether it's nephrogenic or corticomedullary or excretory phase.
Right. No worries. We'll explain the split bolus. So should we just go to the poll quickly? Okay. All right. So yeah, I think most of you all have picked up the right answer. It is the 80 to 100 seconds with nephrogenic phase. Now, mind you, in the exam, sometimes they might just give you the timing. They may not give you the nephrogenic phase, excretory phase, arterial phase, right? So you need to then decipher yourself which phases are taken at what timings. So this question sort of is there to test your knowledge about split bolus and the timing part of it, more of a technique related question. So from the clinical history, uh, you know that the patient has presented with pyelonephritis. Uh, I could potentially take the um, wordings out and say that CT is done to assess the underlying diagnosis, and I wouldn't mention pyelonephritis. So then you would have to then decipher based on the clinical and the lab values that the patient has pyelonephritis, but this does mention it. So just be aware, sometimes you might be required to make the diagnosis yourself and then come to the options. So uh, so what do we do normally? Like G said, we use the single bolus technique where we inject contrast, and then depending upon which phase we want to see, uh, the arterial phase or the nephrogenic phase or the delayed phase, we would scan the patient those many times. Now, this means that every time you scan for a phase, you're radiating the patient for that particular phase. So you're going to do a non-contrast, then you're going to do an arterial phase, you're going to do a portovenous phase or a nephrogenic phase for the kidneys, and then you're going to do a 10 minutes, 5 minutes delayed. So which means the patient is going to get radiated 4 times. Now, the whole point of the split bolus technique is to reduce the radiation dose by reducing the number of phases. Now, how are we going to do that? Basically, as the name suggests, it's a split bolus technique. So you're going to split the bolus or the contrast bolus into 2 parts. Say, for example, you're going to give 100 ml of contrast to a patient. So you will give the initial 30 to 35 ml or 40 ml of contrast initially, and keep the patient on the CT table, but do not radiate him at that point. Just inject the contrast and wait for that contrast to come from the peripheral venous system into his pelvic calyceal system and ureters, which is going to happen at around 10 minutes time. Now, once you do that, then you're then going to inject the second bolus of contrast at 10 minutes time, when you know that the previous contrast has come into the pelvic calyceal system and the ureters and the bladder. So you have the delayed phase already taken care of. Now, if you're only interested in imaging the delayed phase, like the collecting system, ureter, and the bladder, then you may not inject any further contrast. And this one initial phase, if you take at 10 minutes, should suffice and the scan would be over. So you've sort of reduced the number of phases from 4 to 2, and you've reduced the radiation dose as well. Now, suppose you want to examine for the arterial phase, or you want to both the arterial phase and the nephrogenic phase, then at 10 minutes, you would inject the remaining contrast of 60 ml or whatever, and then you would time the acquisition immediately after injecting contrast. If you want an arterial phase, you would do like a typical arterial phase, 20, 30 seconds, and a nephrogenic phase would be at 80 to 100 seconds. So in this particular patient, because we are suspecting pyelonephritis, we are not as such interested in the tumors, cortex, or the vessels, though they would still get opacified. It's not that we would not see them, but we are more interested in the renal cortex and the corticomedullary differentiation. So that is why the nephrogenic phase is important. So this patient would have one non-contrast study and one phase taken at 10 minutes. You inject the first contrast, wait 10 minutes, then you inject the second contrast of 60 to 70 ml, and then image at 80 to 100 seconds after you inject the second contrast. So that is where you're going to be able to diagnose the changes of pyelonephritis, where you have the wedge-shaped hypodensities coming from the cortex up to the medulla. They might be bilateral, asymmetric, perinephric strandings, collections, etc. So you've reduced the radiation dose, you've reduced the number of phases. So where to use this? You can use this in children, you can use this in young women, wherever you want to reduce radiation doses and exposure, especially patients who need repeated scans, say patients who are undergoing stone protocol CTs, or those who are getting followed up for say malignancies. So they keep getting repeated CT scans. So in those patients, the split bolus technique can be very useful. So the whole point of this sort of question is to understand what is split bolus and where you can use it for which phase, as to what you're looking for, whether you're looking for arteries, whether you're looking for the cortex, whether you're looking for corticomedullary function, or whether you're looking for the excretory function. All right, so maybe we'll move on to the next question and the next candidate.
Very quick question just about that, using the split bolus.
Yeah.
Why are we bothering with the delayed phase imaging in this case? Because we're looking predominantly at pyelonephritis, so we're most interested in the kidneys. Why can't we just do a single bolus nephrogenic phase to look for pyelonephritis? Why are we doing the delayed one as well?
So in this particular question, the answer mentions 80 to 100 seconds nephrogenic phase. So we are not doing actually a delayed phase in this patient, because as you rightly mentioned, there is no need to look for the collecting system, ureters and bladder. So for this particular patient, it's only the nephrogenic phase which is the correct answer. Is that the right explanation? Are you happy with what I said, or?
It's more that why does it then say split bolus? Because if we're just acquiring the nephrogenic phase, why are we splitting the bolus as opposed to giving a single bolus nephrogenic phase scan?
Oh, okay. So basically the point is that you are wanting to assess the entire urinary tract in one single radiation exposure. If you do a purely nephrogenic phase and you do not acquire images of the excretory function, um, what happens is in some cases you might need to radiate the patient again, just so that you've seen something on the venous phase and you want another phase to be done, right? But what if you can just radiate the patient once, and only by splitting the contrast into two parts, you can achieve everything. Like you can look at the arteries, you can look at the veins, you can look at the corticomedullary differentiation, and you can look at the collecting system, the ureters, and even the urinary bladder. So you have all this information only by radiating the patient once, which you would anyways would do, right? If you just take, suppose, a plain scan and you do a nephrogenic phase at 80 to 100 seconds, you would still achieve only two radiation doses, right? The non-contrast and the contrast. And even in the split bolus, you're only radiating the patient twice, but you're getting more information than what you would have got if you would only have used the pure nephrogenic phase. So the added value of getting the entire system opacified gives you sort of more information to sort of diagnose everything and make sure that everything is going on well, and the only pathology, or you want to rule out, sometimes the diagnosis may not be certain that there is always pyelonephritis. This question stem makes it quite obvious, but sometimes patients just come with right flank pain. You are not sure as to what's the particular etiology. The lab tests have not yet come in, so you're still sort of thinking, okay, what could it be? So you're also looking for arterial causes or vascular causes. So such cases, the nephrogenic phase can help us not only for the kidneys, but it can also help you for the other structures in the abdomen. You can look at the aorta, the IVC, the branches. So many other things can get evaluated as well by using the split bolus. So it is not just limited to the kidney. Sometimes you might be very uh, lucky enough that you have a very, very particular diagnosis of pyelonephritis, but sometimes patients just come with vague abdominal pain or flank pain where you're not sure from where is it coming from. So in such cases, probably the split bolus is more useful,
Okay,
if that
perfect.
makes
Thank you.
sense. Yep.
Amazing. Thank you.
Okay, so here's the next question. Becky, how are we doing on the time?
Okay, I think we're taking a little extra time, but it should be okay.
Alright.
So I think from the ones on the call, let me just see. Rebecca, would you like to take the next question?
Yes, no worries.
Thank you.
What's your thoughts on this, Rebecca?
Yeah, so I guess from reading this, so she's a 45-year-old lady, palpable lump, and there's sort of concerning features in that there's an irregular mass that's seen, and enlarged lymph nodes, but she's had core biopsies which are normal. So
what's the first thing that makes you think, like, what would you do suppose such a report came to you? You did the ultrasound and you said like it's a BIRADS 4 or a BIRADS 5 potentially.
yeah, so I think if there's like a lot of clinical concern that it's abnormal, then you might have to proceed to do something more radical rather than just accepting that the biopsies are negative. So I don't know that you would need that repeat biopsying would help if you've already taken probably multiple samples. So potentially excision would then be
Okay.
best.
Right. So all the options seem plausible, isn't it? Yeah.
Yeah. It's sort of tricky because I know like biopsies usually kind of give
exactly.
the answer, but then
Yeah,
if you've got a lot of concerning features and potentially the biopsies weren't,
true.
the best samples, then if you've got clinical concern, then I guess you have to.
Yeah, and this seems to be a pretty practical scenario, right? You have a biopsy coming up negative, but we are quite sure that it looks like a very aggressive looking lesion on the ultrasound. So let's go to the poll and then we'll just go to the explanation. All right. So excellent. That's the right answer. Most of you all have picked up repeat biopsy. A few have said surgical excision as well. But let's go to the explanation. So this is something called as the radiology histology correlation, which is used for breast masses. And these are the 5 things which you need to be aware of. So one is the concordant malignancy. What does it mean? Ultrasound or imaging said that it's a malignant lesion or a BIRADS 4-5 lesion, and histology on biopsy also said that it's malignancy. So that's concordant malignancy. So the patient goes for treatment. Next is the discordant malignancy, where on imaging we said that it is benign or borderline. We did not say it is BIRATS 4 or BIRATS 5. We thought it was benign, but the histology came out as malignant. Okay, now these are the few cases where a patient undergoes a biopsy based on the clinical suspicion, or the patient wants the biopsy because if you've said it's benign, or you've said say BIRATS 3, then there is usually a follow-up, but usually never a biopsy done. But if that turns out to be malignancy, that is a discordant malignancy, patient goes for treatment. Then is your concordant benignity. So what is that? It is basically, we have said that it is benign. Histology has also come up as benign. So in these cases, it's not quite clear cut. The guidelines say either you follow up the patient by imaging, or if the patient wants surgery, or if the physician prefers to do surgery, then the patient undergoes for surgery. So that's concordant benignity. Then you have the discordant benignity, which is the case which we just saw, where we have said that it's a malignant lesion. We have said it's BIRATS 4, BIRATS 5, but the histology has come up as negative. The histology says it's benign or it says normal breast tissue. In such cases, two things. One is review imaging, review the pathology slides again, and the patient undergoes a new biopsy. Okay, directly surgery, usually no. It is always a biopsy is repeated first, and then we sort of target different areas than what were targeted before. And then based on that, we again review the histology, the radiology histology correlation, and then patient does undergo definitive surgery if whatever the new pathology report comes up as. Now, but most important to note is whenever there is a discordant benignity, we first review our images and we then schedule for a repeat biopsy. That is more important. Now, for borderline cases where we've also said it's borderline BIRATS 2, 3, and even the histology has also said it's borderline indeterminate, then the patient can undergo surgery because obviously patient factors, physician preference, and all come into play. So these are the 5 important points that you need to look for, and you may have questions based on either of these. Probably commonest would be either the discordant malignancy or the discordant benignity, but the discordant benignity is the one which was tested right now. All right. So let's go to the next question and the next candidate.
Mehdi, can you take this question?
Yeah, sure. I'll go through the question first. Yeah, can I answer this now?
Yeah, go
ahead. So I think for this one, I would go with respiratory distress syndrome. My reason for that would be that one, the baby is premature. Second, he's had perinatal asphyxia. And also, like in RDS, we can see that the lung volumes can be reduced, although there can be a bit of like pleural effusions at times as well. And also the granular opacities in a neonate with that history would lead me more towards respiratory distress. Yeah, I was initially thinking transient tachypnea, but I'd go for, yeah, RDS.
Okay, great. So let's look at the poll. So it is RDS, that's right. So now let's go to the explanation quickly. So basically this question is testing you all based on lung volumes and the history of prematurity and maturity or post-maturity, whether you can come to a diagnosis. So now reduced lung volumes or pulmonary oligemia, there are two conditions that can cause it: respiratory distress syndrome and the group B beta hemolytic streptococcal pneumonia. Now, as you rightly pointed out, that the history mentions perinatal asphyxia, the child is premature. Sometimes they might mention that the child is born to a diabetic mother. So these are predisposing factors for developing respiratory distress syndrome. Whereas in cases of a group B streptococcal pneumonia, you would not have those kind of appearances. What is described, and for the purpose of the 2A exam, is respiratory distress syndrome does not have a pleural effusion, and we do not see it in regular practice. Uh, Whereas a group B streptococcal pneumonia does have a pleural effusion. So the question stem does mention that there is a premature baby born to a diabetic mother, perinatal asphyxia, reduced lung volumes, which means there is pulmonary oligemia, and there are bilaterally symmetric ground glass or granular opacities, and no pleural effusion, right? Now, if you have increased lung volumes or pulmonary plethora, the typical conditions would be a transient tachypnea of newborn. This is typical as the child is born via C-section, so the squeezing effect of the birth canal is absent. That's why the lungs will accumulate fluid, so you'll have plethoric lungs and there will be pleural effusion. Typically, they would be term or post-term babies. It would not be preterm babies. Meconium aspiration syndrome is when the child has aspirated meconium. Obviously, that's going to result in a plethoric lung. Sometimes you might have a pneumothorax as well. And bronchopulmonary dysplasia is something of a chronic issue where patients who have respiratory distress syndrome are on mechanical ventilation, and over a period of few weeks and potentially months, they can develop these cystic lucencies in their lung on the chest radiograph, and there will be increased lung volumes because of the mechanical ventilation. Whereas this patient has been described as premature, and immediately after the birth, he's landed up in the NICU. So it is not a chronic issue, at least as far as this question is concerned. Right.
Thank you.
Okay, so well done. Let's go to the next, and that's the question. Anybody would like to take this?
I would just ask can you take this case?
Yes, let me go through the question first.
No problem.
This one option is not being shown, and I will scroll down once you all have read through it.
Not quite sure actually.
Mm-hmm.
So the extradural hematoma is frontal, and 2 days later with progressing symptoms, I'm thinking the hematoma will push.
Yeah.
So
So say you have an extradural hematoma,
yeah.
right? So that will cause mass effect, midline shift, and hydrocephalus typically, right? Depending upon the severity, but you usually have mass effect, right? So with this piece of information, what makes you think?
I'm just guessing medial lobe of the temporal, medial part of the temporal lobe push into the MBS system up against the brainstem.
All right. Okay. All right. No worries. We'll go through the explanations in detail. Let's look at the poll, I suppose. So half of y'all have said cingulate gyrus being displaced beneath free edge of Fox, which is the right answer. That's great. So let's go to the explanation. So what does the question stem describe? The question stem is essentially describing what is a subfalcine herniation, or commonly known as midline shift, which we commonly see, right? So the schematic on the left is sort of telling you the different brain herniations. And on the right, you have the axial CT, which is showing you how to measure and what a midline shift would look like. So basically, if you look at the schematic, the cingulate gyrus is here, and this is the falx. So when the cingulate gyrus goes underneath the free edge of the falx and crosses onto the other side, is what you have as a subfalcine herniation or a cingulate hernia. Now, how do you measure that? You go at the level of foramen Monro and then you draw an imaginary line, or you can actually draw that line on the CT from the anterior-most point to the posterior-most point in the midline, and then you draw a horizontal line where you can then see the midline septum meeting this line which you've just drawn. Now, if it is less than 5 millimeters of midline shift, it is acceptable. More than 15 millimeters in this context of being a hematoma or a mass or whatever that could be, patient usually needs surgical intervention for that. Now, if you imagine this extradural hematoma here and it is going to compress this brain and it is going to result in the cingulate gyrus going on the other side, this ventricle is going to get compressed. Probably the foramen Monro might get compressed as well, and then you're going to get hydrocephalus developing. Plus, what happens is when you have the mass effect happening, you can imagine the anterior cerebral arteries are running here at a more caudal section, and you're going to get the anterior cerebral artery getting compressed by the mass effect caused by the subfalcine herniation or the cingulate gyrus compression. Now that is going to be causing an ACA infarct on the side of the problem where the hematoma or the tumor is, and the ACA infarct on the right side is going to produce contralateral leg weakness. So that's what the question stem is describing for you, is that 2 days later, the patient who had a right frontal extradural hematoma is now presenting with a left lower leg weakness, right? So the explanation for that is the ipsilateral anterior cerebral artery is getting compressed by the mass effect, causing contralateral leg weakness. Now, these are very commonly tested brain herniation syndromes because you will have contralateral weakness on this side and the trauma happening on the same side or the other side, and we'll go through them now. So that's a falcine herniation. Then you have something as the transtentorial herniations. So basically, as the name says, the herniation is happening through the free edge of the tentorium, right? Now, this can be two types, downward or upward. So again, self-explanatory. Downward means there is a problem which is there in the top, which is compressing or pushing things down. So downward transtentorial herniation. Now that can be again in two types. It can be a central type and it can be a lateral type. Now again, it just depends upon where the location from where the compression is happening. If you have a lateral type, which means lateral structures are getting pushed downwards. So again, assume this extradural hematoma here, you have a compression of the medial part of the temporal bone, which is called as the uncus, that is getting pushed downwards into the tentorium against the brainstem, right? So what's going to happen is that this is also commonly called as the uncal herniation. So uncal herniation technically is the lateral type of downward or descending transtentorial herniation, if you want to remember that for your exam. Now, what happens is when the uncus goes down and presses against the brainstem, the posterior cerebral artery sits here, that's going to get compressed. So you can have compression of posterior cerebral artery and infarcts happening in those territories and symptoms happening because of compressions in those territories. The brainstem gets compressed. The pons and the medulla, because of this compression, can show bleeds. Those are called diurete hemorrhages. Again, this is high yield. If they mention diurete hemorrhages, that is hemorrhages in the pons and medulla. This is usually because of a lateral type of descending transtentorial herniation. Other interesting thing which happens is something like when you have this uncus of the temporal lobe compressing downwards, the contralateral midbrain is going to get compressed. Now imagine this uncus is pressing, and this is the right half of the midbrain and the left half of the midbrain. So this compression is going to result in the right midbrain getting compressed against the bone here. Okay. So this is called as the Kernohan's phenomena. So what's going to happen is you will have weakness on the same side of the injury, which is unusual in the brain, because you know when there is a weakness on, say, the right side, you would expect a problem on the left side, right? Unless you're looking at cerebellar pathologies. For supratentorial pathologies, whenever there is a, say this patient had a left-sided extradural hematoma and the patient then presents 2 days later, same question, I can twist it and I can ask you, he has an extradural hematoma, etc. 2 days later, he then presents with left-sided weakness. Okay, and then I sort of somehow tell you that the uncus was the, or the uncus of the temporal lobe was the one which was getting compressed. So what has happened? The uncus of the left temporal lobe is compressing the right side of the midbrain, because of which he's got left-sided symptoms now, right? So uh, this is just one way of understanding how they can sort of play with your clinical symptoms and your understanding of how the compression syndromes work, and that's how the patient is going to present. So it's very important that you all understand this. So this is the lateral type. Now the central type is again quite explanatory, where there is some sort of a mass which is present in the center, in the basal ganglia or the thalamus or something, and is going to compress these structures straight downwards. There's nothing on the lateral, it's more centrally placed. So that's the descending or the downward transtentorial herniation. Now the upward or the ascending type of transtentorial herniation is the same thing. Things are herniating through the tentorium, but now yeah, they are going from below up. So obviously there has to be some mass or something going on in the posterior fossa, which is then going to displace the cerebellum through the tentorium. And what's going to happen? The PCA and the scar is going to get compressed. You might have potentially compression of the fourth ventricle, so that's going to cause hydrocephalus. So that's how you know it's an ascending or an upward transtentorial herniation. The most important common cause is a posterior fossa mass, which can cause that. Now, you can also have a downward uh, herniation, which we commonly know is the cerebellar tonsillar herniation, right? So that's the one which we commonly see when the cerebellar tonsils are below the level of foramen magnum. This is potentially a neurosurgical emergency. The patient needs to be urgently looked at by the neurosurgical team and probably operated. Otherwise, the patient can cone and die. Now, you have something called as the transalar herniations as well, and they are of two types again, descending and ascending. So what happens in a transalar herniation is basically the frontal lobe is getting compressed um, posteriorly and inferiorly. Okay, so this is the frontal lobe. So these are slices going from cranial to caudal. You have some sort of a mass with a lot of vasogenic edema here. And if you go on the inferior most cuts, you'll see that the posterior and the inferior part of the frontal lobe is getting pushed downwards. Uh, This is the region of the sylvian fissure. You have the middle cerebral artery running across here. So when that happens, the middle cerebral artery is going to get compressed on the sphenoid wing, and it is going to result in MCA infarct, right? So the patient initially has presented with frontal lobe issues, gets a compression of the MCA, develops an MCA infarct, and obviously this would result in a contralateral left-sided weakness, because in this case the pathology is on the right. So again, contralateral, ipsilateral, right? So, but if you understand this, it's not very difficult. So that's the transalar descending herniation. Now, what's the ascending herniation? So in descending, we saw that there was a pathology in the frontal lobe. Obviously, when there is an ascending herniation, guess where the pathology is going to be? It's going to be either in the middle cranial fossa or temporal lobe, and things are going to be getting pushed up. So the temporal lobe is going to get displaced superiorly and anteriorly, and you're again going to get compression of the MCA, but here it is the temporal lobe which is going to be pushing it from below up rather than the frontal lobe pushing it downwards, again against the sphenoid ridge. Again, you will have primarily temporal lobe pathology, developing a secondary MCA infarction, and patient having contralateral weakness, right? So you will probably, the question might come up as, like a hypodensity in the frontal lobe, which is showing some enhancement. 2 days later presents with left-sided weakness, and now there is a fresh hypodensity in the parietal lobe or in the frontoparietal region, something like that. So they're trying to point out to you. So these may seem as difficult questions, but if you can sort of understand the mechanism behind it, you may be able to answer them. Okay, so any questions on this? All right, so that's the next question. And this has got some options which are going below. So I'm going to be scrolling down slowly. And anybody wants to take this?
Inken, if you are able to take this, you can. If not, anyone else who would like to go one more time?
It's okay if you all don't know this. Tower questions are not um, sort of very common, but if you get them, you'll be able to answer them.
G, if I thought I saw you unmuting, if you'd like to just go ahead.
Oh, yeah, I can give it a go, but sorry, I haven't looked at all the answers yet. Sorry.
Yeah, no worries. Just take your
Take your
time.
time.
Thank you.
This is question 8, Becky. I think we have 2 more, and I don't think they would take as much time.
Sorry, can you say that again? It's the 8th question you said, right?
Yeah, this is the 8th question. This might have a little bit of some time required, but the last 2 probably might not take so much time. So
That's okay. I think we still have time. So yeah.
okay. So I'm just going to scroll down to show you all the last 2 options.
We're a little over the, sorry, G, 1 second. We're a little over the time on the timetable, but we did start by, 9:45, I think. So it should be okay. Yeah.
All right. Okay. Yes,
So,
G.
yes, I don't know if this is the correct answer, but I thought that for the sort of imaging, we would need an ECG gated images of the heart, and we would need a CT angiogram of the aorta and the iliofemoral vessels for access. So here, I think the question, it came down to choosing whether for the CT angiogram pre and post contrast, whether it needs to be ECG gated or non-ECG gated.
Correct.
I think that was the choice that it came down to. They chose ECG gated prospective cardiac CT, but I thought that the CT angiogram of the vessels didn't necessarily have to be ECG gated, so I chose
Correct.
option 2, I think.
Okay. So that's fairly good assessment of the way you've thought through this. So TAVR requires cardiac CT, and it requires an angiogram of the aorta iliofemoral vessels for access, as you correctly mentioned. The other thing which you mentioned is the cardiac CT has to be ECG gated. The angiogram of the aorta and iliofemorals does not need to be ECG gated. So that's correct as well. So that can help you to narrow down options. Now, what you would be left with is whether the cardiac CT should be prospectively gated or retrospectively gated, because the other 3 options are out. So that is where your understanding and factual knowledge about cardiac CT would come into play. So the options might seem confusing at the beginning, but as G has rightly worked through it, you can sort of narrow it down to a couple of options and then use your factual knowledge to come to the correct answer. So what does the poll say? So the poll says ECG gated retrospective CT and non-ECG gated pre and post. Then it says, okay, this doesn't say, okay, let me go back. Yeah, now it's fine. So then it says, okay, so we have like a split amongst almost all the options, and nobody's picked up this, which is good. So now let me first ask y'all if anybody of y'all are doing TAVR CTs or cardiac CTs. Are y'all aware about it or anything? So basically, cardiac CT is ECG gated. That is because we need to image the heart when it is rested or relaxing. Okay. Now, the heart is the most relaxed when it is in diastole, obviously. So we are going to be using the ECG data or the RR. I'm sorry. Yeah. Okay. So we are going to be using the ECG data to know where is the RR interval. And based on that, we are then going to decide, okay, if this is the RR interval, and then somewhere here is where the heart is going to be relaxed, because we know that this is ventricular contraction, which is the QRS complex, and this is the P wave, which is the atrial contraction. So this point here, which I'm showing with my arrow, is the point where the heart is in diastole, which is the most relaxed part of the heart, which is what you need to image the coronaries. Mind you, I'm speaking about coronaries first, and I'll come to the TAVR in a minute. So when we are imaging the coronaries, we want the heart to be as relaxed as possible, because the coronaries, if they are moving, will not be able to image them or see them clearly. So we use ECG gating. Now, ECG gating can be of two types: retrospective and prospective. So what is retrospective? Retrospective is basically you are not limiting your radiation to any part of the cardiac cycle. You are imaging the entire cardiac cycle, right? You are imaging via the P wave, QRS, T, everything, and throughout all the cardiac cycles. So you get everything in that. Now that's great. You will have no missed data. But what is the problem? The patient is going to get radiation, right? The patient is going to get very high doses of concentrated radiation to the chest. Now, if you decide, okay, and what determines whether you would want to do retrospective? If the patient has poor heart rate control, where you're not sure whether you're going to get good images, you would use retrospective. Again, I'm all speaking about coronary now. I will come to TAVR. When you're doing a prospective for the coronaries, if the heart rate is having very good control, say it is 50, 60 or something, or if your scanner is excellent, then you can do something called as prospective, where the tube is going to emit radiation only during the RR interval, right? Only a specific portion of the RR interval, not even the entire RR interval, or not even the entire diastole, a particular part of the diastole. So this is your diastolic phase, this whole thing, and you are giving radiation only in a particular part of the diastole. So that's prospective. So less radiation, it's quite obvious because of this, but there's a chance that you might have some missed data, because you're going to be sort of using all this data is not available. Whatever is the non-highlighted part, you don't have data here. You only have data here. So if this is good, you're good. Otherwise, there might be a loss of data there, but the radiation dose is less. Or what you can then sometimes do is a retrospective tube modulation, where you are giving more radiation during the particular phase of the diastole, say 70 to 80%, and the rest of the time your tube current has gone down. So you see the tube current is low here, goes up, goes down, goes up. So the radiation dose is sort of between prospective and retrospective, but at least you don't have missed data. So in case there is, say, some abnormal heart rhythm comes up, or if the patient's heart rate suddenly jumps up while giving contrast, you can still reconstruct something based on these phases and not just fully rely on these phases. Now, when you come to the TAVR protocol is basically done whenever the patients have to have the aortic valve replaced. Initially, they would have it done surgically. Now they have it done via the interventional radiology guys, where they do a transaortic valve replacement. That is what TAVI stands for. So CT is the gold standard for the pre-procedure assessment and post-procedure assessment. Now, pre-procedure assessment, you have to image the heart, and it has to be a retrospective acquisition, which is what is mentioned in the answer, right? It is not a prospective acquisition. We are not worried about radiation as such. The reason being, these patients are usually 70-year-olds and 80-year-old patients. And most importantly, in the retrospective, you have the entire data which is available to us, because I'll tell you, we need to have measurements done at specific levels of the aortic root and the aortic annulus, and the retrospective study will give us no missed images. There will be no reconstructions which will be happening, which are done by the machine. We will have the actual data with us. So that is why we need the retrospective data set for the TAVR, and then a non-ECG data, obviously, for the aortofemoral vessels for the vasculature. Now, what are we looking for? This is beyond the scope of this talk, with this study group, but broadly speaking, we are going to be assessing the valve morphology. What is the underlying aortic valve type? Bicuspid, tricuspid, quadricuspid. We are going to be taking multiple measurements for the particular prosthesis which is going to get inserted. They need an exact measurement of certain measurements of the ascending aorta, so that they will customize the valve, the valve which they are going to implant based on RCT measurements. So we have to give them absolutely millimeter specific measurements of the landing zones, the coronary ostial heights, the measurements at the sinus of Valsalva, tubular junction, and so on. And then cardiac findings, and most important is the vascular access, which is why the angiogram of the peripheral vessels is done, to look if the vessels are accessible. Is there any atherosclerosis? Is there too much calcifications? Which vessel is accessible? Is it the right or the left? If not, then can we go through the subclavians, and so forth, and then non-cardiac findings. So this is basically is a sort of a very, very short explanation for TAVR. But what you need to know is it is a retrospective ECG gated acquisition for the heart, and a non-ECG gated acquisition for the aortofemoral vessels. All right. So this is the next question.
Noha, can you give it, would you like to give it another go? And Noha, are you able to hear me?
Yes.
Would you like to give it another go?
That's okay. Okay, 66-year-old woman present with hypercalcemia on ultrasound. There's solid heterogeneous nodule close to the lower pole of right lobe of thyroid. What is the most appropriate test to diagnose? Well,
So would you want to guess, or
yeah,
what you're thinking? You can just tell me
I
what you're
think
thinking.
I will exclude systemic gallium.
Mm-hmm. Okay.
Maybe I will choose technetium MTB bone scan. I'm not sure.
Mm-hmm. So where do you think is the pathology? Like in which anatomical part of the body is it?
Yes, heterogeneous nodule in the right thyroid lobe.
So it says close to the lower pole of right lobe of thyroid.
Okay.
So, and it says hypercalcemia. So what does it make you think? What's going on clinically?
So it could be differential with parathyroid hyperplasia.
Right. So for parathyroid, what would you like to do then? Would you want a bone scan for parathyroid?
I think maybe systemic.
Mm-hmm. Okay. Right. Good.
Thanks.
So you worked through the question and you got the answer, right? That is what is going to be tested in the exam. Yeah. So if you just pay attention to the question. The
yes, I read
patient
it
is
as it's like in the lower pole of right lobe of thyroid.
yes, exactly. So just be very careful, because there will be like one or two words which will take you away or towards the diagnosis. So elderly lady having hypercalcemia and nodule is close to the lower pole of the right lobe of thyroid. So obviously we are going to do a system PV scan, because the suspicion is a parathyroid adenoma, right? Now, how do you, so this is basically done to localize the parathyroid pathology. We are lucky in this patient because it's the exam that we've mentioned that there is a nodule close to the lower pole of thyroid. In actual clinical practice, sometimes you may not see anything on the imaging, uh, especially on ultrasound. You may not pick up anything. So in such situations, when the patient has got very high calcium and you don't know where it's coming from, that is the time when you will do a system EB spect to localize it, whether there is a parathyroid lesion anywhere in the body which is producing this high calcium and is producing these symptoms. So increased uptake and persistent activity on 2-hour delayed images, and then you can combine it with a CT and do a SPECT CT and then localize it on that particular study itself. Like the SPECT shows you where the increased uptake is coming in from, and then the CT tells you, okay, which is this organ or whatever. Okay, so in practical life, it may not always be possible that you would be sort of seeing a nodule, which is what described. So, or they might just tell you it's hypercalcemia and ultrasound of the neck is negative, or ultrasound of the neck is normal. What is the next best step? So you would still pick up system UV spec because you're suspecting a parathyroid adenoma. It has to be ruled out. Now, gallium and octreotide are for neuroendocrine tumors, and MIBG is for pheochromocytomas and paragangliomas. MDP bone scan is obviously for bony pathologies. But once you've sort of read the question and come to a conclusion that it's the parathyroid that you're looking for, then you can pick up the system EB spec. This is what this question wanted to test. All right, good. So this is the last question.
I can take it.
Yeah, go ahead.
I'm not really sure, but maybe non-selective embolization with gel foam because he's hemodynamically unstable, so we have to stop the active bleeding first. That's why I choose.
Great. Okay. So that is actually the right answer. So now in this particular case, you have an hemodynamically unstable patient. Multiple bleeders are seen on angiogram. Now, what do you do in such case? What is the most important thing to do in such patients is to not look from where the bleeding is coming from, but to stop the bleeding first. Okay. The most important thing is to just stop that bleeding from happening. Now, if you do very, very selective sort of embolization, either proximal, distal, or super selective, what's going to happen is you don't know where the bleeding is coming in from. So you might go and do, say, an embolization, and that might infarct the organ which it is coming from if it is an end organ blood supply, say the kidney. Suppose the bleeding is coming from the kidney and super selective embolization is done with coils, and you coil that vessel there. So you will get an infarcted kidney after that, right? So you don't want that from happening. So the first important thing is to note that the stopping of the bleeding is the primary objective. That is where gel foam comes into place because it is non-selective and allows for future recanalization. It will stop the bleeding, but it will not sort of make it an irreversible process. You can always go back and do definitive procedures later. Whereas super selective, usually done in stable patients, when you know where the organs are, you're going to be targeting at, you have to preserve the end organ tissue and you have to avoid ischemia. So very important, you select this only in stable patients. Distal embolization with particles, again, it can become permanent. You don't want that, and it's going to take time as well. In a bleeding patient who's hemodynamically unstable and he's in front of you losing blood and dropping blood pressure, you're not going to try and do selective or super selective or distal embolization, right? You're just going to be practical and you're just going to say, let's stop the bleeding and let's look at it later again. Similarly, proximal embolization with coils in splenic bleeds and collaterals. But the basic point is this, right? You just want to be non-selective initially, and then as the patient stabilizes, become selective. Depending upon the organ of origin, you do a CT, you identify it, and so on and so forth. Okay, I think this is the end of it. So any questions? I guess we've already run out of time.
Does anyone have any questions?
We're going to be taking any feedback from them, Becky?
Yes, we are.
Okay, great.
Just gonna
So
put in
that,
the feedback link.
yeah. So that'll be good to sort of know as to what they would want to be done better on
Yes.
the future session.